What are the steps to manage a woman presenting with chronic pelvic pain? How can heart failure survival rates be improved? What are 3 things you need to know about hearing loss? Hello and welcome to the Clinical Update podcast, where we will look at the answers to these questions. My name is Sangeeta Krishnan, and I'm your host for this episode. Joining me in the studio are Dawn Powell and Pat Anderson, who will be talking about chronic pelvic pain in women. Our special guest for today is Professor Clare Taylor, who will talk to Dawn about early diagnosis of heart failure. And finally, we will bring to you 3 key points on hearing loss. But first, over to Dawn and Pat for a discussion on chronic pelvic pain in cisgender women.
Thanks, Sangeeta. This is a module by Miss Samantha Kirkwood, Dr. Charlotte Cutler and others from the Royal Surrey NHS Foundation Trust. They state that the Royal College of Obstetricians and Gynecologists define chronic pelvic pain as intermittent or constant pain in the lower abdomen or pelvis of a woman for at least 6 months in duration, and it is a pain that is not exclusively caused by menstruation, pregnancy or intercourse.
So why is this an important issue to cover?
Well, chronic pelvic pain is a common presentation in primary care, affecting approximately 1 in 6 women. It carries a significant economic and social burden. Just to note, while we are focusing on cisgendered women, chronic pelvic pain can also affect trans men and non-binary people who are assigned female at birth.
So I'm sure our listeners know this, but chronic pelvic pain is, as I understand it, a symptom rather than a diagnosis.
Yeah, so Ms. Kirkwood and colleagues state that chronic pelvic pain should be regarded as a symptom rather than a diagnosis. They add that it is imperative that clinicians use a holistic approach when treating people with chronic pelvic pain because effective management may include multiple treatment modalities.
Okay, and so what might chronic pelvic pain be a symptom of?
Well, firstly, fluctuating cyclical pain is likely to be gynecological in origin. It can be part of a triad of symptoms. Alongside pain during intercourse and period pain, chronic pelvic pain can be part of a triad of symptoms that indicates adenomyosis and endometriosis. The authors comment that these conditions can occur in adolescence and therefore should not be overlooked as a cause of chronic pelvic pain in people who are under the age of 18 years.
So there are a lot of other potential causes, I think?
The causes of chronic pelvic pain are multifactorial and can include adhesions from previous surgery, IBS and interstitial cystitis. There is also a correlation between chronic pelvic pain and psychiatric disorders.
So we were discussing this point about psychiatric disorders yesterday. What are your thoughts on that, Dawn?
I think we do need to recognise that many women feel that healthcare professionals have dismissed their pain. They've been told it's all in their head when their pain actually has a very real physical cause. But also, there can be a relationship between pain and psychiatric conditions. So a psychiatric condition could play a role in pain, but that does not mean a woman is imagining it or making it up.
So one thing I liked about the module was the way that at the end of the section about causes, it presented a case study of a young woman with a history of painful periods. And that would hopefully trigger a learner to think about how they would approach that patient. And then the module leads on to the assessment section, which then leads on to management. So I thought it was quite a nice progression.
Yeah, to add to that, I would say take a look at the assessment section in the module because it really is very well put together. The authors say that GPs should allow plenty of time for initial consultation with a woman presenting with chronic pelvic pain to really explore the potential causes. They also suggest discussing with her how the pain is affecting her quality of life. And importantly, they recommend advising a woman to keep a diary across 2 to 3 menstrual cycles, as this diary could then provide an insight into the pattern of the pain and, as a result, the cause.
That sounds really worthwhile, although I imagine it would take quite a lot of time, might require some repeat appointments, perhaps.
Yeah, I mean, so they're sort of saying in the initial consultation allow plenty of time, and that just might not be achievable. So that consultation might have to go across several appointments.
And after assessment, the module talks about taking a structured approach to management. And what is this approach?
So the authors outline 3 key principles. 1, hormone therapy for women with cyclical pain. 2, antispasmodic agents for those with IBS. And 3, adequate pain relief.
So wouldn't some of those principles depend on a cause being identified? So what happens if you haven't yet identified the cause?
Well, even if a cause has not been identified, a woman with chronic pelvic pain will still need support. So in these situations, a woman should be given time to explore her beliefs about the pain, and then she and her clinician together can then develop a management plan.
Thank you.
Well, and thank you for discussing this module with me. Just to mention, this module has been really popular with our readers, so I really do recommend taking a look. In fact, I recommend taking a look at our Women's Health page because there's lots of great content there.
Thanks very much, Dawn and Pat, for those insights. And now, Dawn will interview Professor Clare Taylor.
Thanks, Sangeeta. Here with me today is Professor Clare Taylor. She is a Professor of General Practice at the University of Birmingham, and her research interests include the earlier diagnosis of heart failure. Today, she will be talking to me about the barriers to earlier diagnosis. Welcome to the podcast, Professor Taylor. So, to start off with, heart failure survival rates have not really improved over the last 20 years. Why do you think this is?
Thank you for having me. So our research looked at large GP data set to determine trends in survival from the year 2000 up to 2017. And what we found, there was only a very gradual and really quite small improvement in survival rates during that time over nearly 2 decades. And that differs quite considerably to other conditions, particularly, for example, cancer, where we've seen a huge increase in survival rates, which is obviously a really, really good thing. The data doesn't tell us why we have seen a stagnation in survival for heart failure, but heart failure traditionally hasn't seen the same investment as things like cancer. So the National Cancer Plan in 2000 saw a real investment in the whole diagnostic and treatment pathway for people with a diagnosis of cancer. And we haven't seen that same focus for heart failure over the years. It's also a condition that is diagnosed at a relatively older age, so a median age of around 76 for diagnosis. And patients often have other long-term conditions as well. So it's quite a complex situation with multiple things going on. But my research interest is really looking at how we can diagnose heart failure earlier, because we know from randomized controlled trials that there are lots of treatments now that we can offer to patients which improve both the quantity and also the quality of patients' lives, but getting that diagnosis is really key to then starting those treatments early.
Is it right that heart failure tends to be diagnosed in hospital when it's at a later stage and a bit more difficult to treat?
You're absolutely right. So data from the British Heart Foundation shows that up to 80% of new diagnoses of heart failure are made in hospital. And from our data on survival, we found that people diagnosed in hospital rather than the community had a worse survival, and those survival rates hadn't improved to the same extent as the people that are diagnosed in the community. So what we need to do is be diagnosing people earlier at a more treatable stage within primary care. So identifying people that potentially have heart failure and doing what we call a natriuretic peptide blood test. Natriuretic peptides go up when the heart is under strain, and it's a way that we can tell whether or not heart failure is likely and whether or not we need to refer for further assessment with echocardiography and a specialist review, usually by a cardiologist.
What are the red flags of heart failure that a GP might see? I mean, I'm guessing that breathlessness is one.
Yeah, as you say, patients commonly present with things like breathlessness if they've got heart failure. The other key symptom is tiredness or exhaustion. And the other thing is swelling, particularly ankle swelling. And these are the 3 key symptoms that we see in patients with heart failure. But these are symptoms that exist in lots of other conditions as well. So it can be difficult, particularly if patients already have other long-term conditions. We need to think about heart failure as well as the symptoms being related to the other things that we already know that they're diagnosed with. People who have had, for example, a previous heart attack, or people that have diabetes are at higher risk of heart failure compared to the general population. So that puts them in an increased risk category. But it's a case of us really thinking heart failure when we see patients that are breathless.
You were saying before it's about the NT-proBNP test, and like NICE sort of say anybody with suspected heart failure should be given one of these tests. You have a patient and they're sort of coming with breathlessness and you should be thinking about heart failure, but is there anything that GPs should be doing to ensure that more people are getting these tests?
Yeah, so you're right. We did some other analysis using a large GP data set between 2004 and 2018 to see what the usage of the natriuretic peptide blood test was like within primary care. So in 2010, NICE recommended it as part of the guidance for people presenting to primary care with symptoms that might be heart failure. They recommended that people have a natriuretic peptide blood test. And we did see a really big increase in the use of this testing from 2010 onwards. But what we also found was even by the end of the study in 2018, only 1 in 4 patients had had a natriuretic peptide blood test in the 6 months prior to diagnosis. So 3 out of 4 patients hadn't had that blood test. And it's really a key part of the diagnostic pathway, because if we do the blood test and it's raised, we refer for echocardiography and specialist assessment to confirm the diagnosis. If it's not raised, then we can think about other reasons why the patient may be breathless, exhausted, have swollen ankles, but it's absolutely key. And if we're not testing, then we're less likely to be referring for appropriate diagnosis by the specialist.
Okay, so you're talking about referral to a specialist. NICE says that a patient with a NT-proBNP of between 400 and 2,000 nanograms per litre should be referred within 6 weeks, and that a person who has an NT-proBNP of more than 2,000 nanograms per litre should be referred within 2 weeks. Is this easier said than done?
Yeah, that's right. So NT-proBNP blood test is something we can request as GPs. If we get it back and it's above 2,000, that means that is a potentially more severe heart failure. So we need to diagnose and treat earlier, because these people are more likely to end up in hospital. And some of our research has shown that above 2,000 is a really key cutoff. And so NICE recommend this 2-week time frame. So we need to be doing an echo and specialist assessment to get that diagnosis, start treatment within 2 weeks. If it's 400 to 2,000, the time frame is recommended as 6 weeks. So still a fairly rapid diagnosis. In reality, the problem is within the diagnostic pathway, there are problems with capacity. So particularly around getting an echocardiogram, there is a real issue around the number of echocardiographers within the NHS, and we need more of them. So there can be a delay in getting an echo. And without an echo, you can't really confirm or rule out the diagnosis. So whilst these timeframes are supported by evidence and will improve patients' diagnostic journey and outcome, in reality, within the stressed NHS at the moment, we're often seeing that these timeframes are just not met. And some of our other research using big GP data shows that the average time between presenting with symptoms and getting a diagnosis is far outside of these ideal timeframes that NICE do recommend.
So going forward, perhaps a priority is to try to get these waiting times down. And of course, that's a resource thing, and that's probably a bigger issue than GPs can really deal with.
Yeah, absolutely. So if we see somebody and think, let's do a natriuretic peptide blood test, when we get that result, we need a pathway which will rapidly lead to diagnosis. And as I've said, there are certainly delays there. But as our research also found, 3 out of 4 people aren't getting that blood test to start with. So what we need to do is look further down the pathway at the start to look at what is happening in terms of patients presenting to their GP, and then what's happening within primary care in terms of investigations and diagnosis. Some of my research was interviewing patients with a new diagnosis of heart failure and asking them about their diagnostic journey. And one of the things that came up was actually heart failure isn't something that the general public are aware of. So patients often didn't necessarily realise what their symptoms were, and certainly people didn't go to their GP thinking, is this heart failure? And they often went at a relatively late stage when their symptoms had got quite bad. Patients had put the symptoms down to getting older or being a bit out of condition, or down to their other long-term conditions. And it was sometimes a family member that enabled that initial contact with medical services, sometimes through primary care, but sometimes their symptoms were so bad they just called an ambulance to take them directly up to A&E. And that is what we find, that patients can present at a relatively late stage where they do need hospital treatment for intravenous diuretics to offload the fluid of heart failure and get them stable, so we can get them on all the drugs which we know improve length and quality of life.
Essentially, aside from the issue of these tests not be done, the patients aren't coming to the surgery when they need to come. And I think you've actually tried to address this by coming up with is it BEAT, this an acronym to help patients understand the signs and symptoms of heart failure. What does BEAT stand for?
Yeah, that's right. So I'm on the clinical advisory board of the patient-led charity Pumping Marvellous Foundation. And we had a workshop in 2018, and I came up with the acronym BEAT, which is breathless, exhausted, ankle swelling, time for a simple blood test, time to see your GP. And this was really inspired by FAST for stroke, face, arm, speech, time to call 999. And this was an attempt to raise awareness of heart failure in the same way that FAST had raised awareness of symptoms of stroke. The difference being, though, in FAST, you want to call 999 to get into hospital to get a rapid diagnosis of stroke in order to access thrombolysis therapy. But with BEAT, what we want is people to have a simple blood test in their general practice that will then lead to a diagnosis of heart failure and keep them out of hospital rather than needing to be admitted through ambulance to hospital. So this is an acronym that's really caught on, actually. So the charity Pumping Marvellous Foundation have run BEAT HF campaigns, initially in the Northwest and also more recently in London. And it's to really raise awareness amongst the general public. So BEAT was on billboards, on Classic FM, and we had patients contacting the charity, including a daughter who had heard the Classic FM advert for BEAT and realised that that was what was going on with their parent, and that actually initiated a process of the diagnosis of heart failure because she took them to the GP and then things happened from there. So I think there is a real need for these public awareness campaigns. But also within general practice, as GPs and practice nurses, we also need to be thinking of heart failure when people come to us. So we need to think about BEAT, breathless, exhausted, ankle swelling. Could this be heart failure? Do we need to be doing a natriuretic peptide blood test? And I think it's a way just to raise awareness in the context of all the long-term conditions that we're dealing with, just allows us to think for a second, could this be heart failure?
Okay, so you're saying you've had a good response from patients to this acronym. What can GPs do to raise awareness? Could they put posters in their surgery? Is there campaign materials they could use?
Yeah, that's right. So the charity have developed campaign materials, including, exactly as you say, posters, which you can put up in your waiting room, which has the BEAT acronym and says what BEAT stands for and what to do. I also do lots of talks to GPs just to talk about the BEAT acronym and how we can increase our suspicion for heart failure. And all the GPs that I've spoken to so far have really liked the acronym because it's very simple. It's similar to FAST, which was very effective. And you can just write in the notes, no BEAT symptoms, or at least that you've considered it. So I think it's an acronym that is useful for the general public, for patients who may be experiencing symptoms, and within primary care, just to consider heart failure. And if we look at all the different parts of the diagnostic pathway, we need to intervene at all stages so that people are more likely to consider heart failure in the general public, go and see their GP. The GP or practice nurse is more likely to think, could this be heart failure? Do a natriuretic peptide blood test. And even within the hospital setting in A&E, if somebody comes in breathless, the physicians at the front door can be thinking, beat, could this be heart failure? It may not be down to their existing long-term condition like obesity or COPD. Actually, could this be heart failure? Do we need to be doing natriuretic peptide blood test in A&E? So I think it's an acronym that hopefully will really increase in usage and become, like FAST, just part of the medical dialogue.
With heart failure as a term, do you think that needs revising at all? Obviously, I'm not a medical professional. I don't really understand the terminology, but that sounds like a very basic term for what it is. And it's almost off-putting because you think, oh, heart failure, I'm going to die. But it's actually more complex than that.
Yeah, absolutely. And when I interviewed patients who'd had a recent diagnosis, some patients said that to me, that's what they thought the term meant. And almost everyone I spoke to found it incredibly frightening. And you're right, it doesn't really describe what is going on. Heart failure is when the heart is under strain and not able to meet the metabolic needs of the body. But it doesn't mean that it's completely failing or that it's going to stop. And so we've had a lot of discussion about the terminology. And the problem is that it is a very well recognized term, and all the literature refers to heart failure. All the trials are done in people with heart failure, and there's universally agreed definitions of heart failure. So to change the terminology would really need a global effort to come up with a new term that everybody was happy with, patients, researchers, clinicians, and that everybody was going to adopt at the same time. And I think that just hasn't happened. But I think the problem with the term heart failure is now well recognized. It's unfortunate because I think that can put people off. And some patients that I spoke to actually didn't realize they'd got heart failure. I think sometimes as clinicians, we can be reluctant to use the term because it's so frightening. So we might say it in a different way, but actually people need to know the diagnostic label in order to get the best and the most effective treatments for the condition that we do still call heart failure.
So just finally, MIMS Learning is focusing on addressing health inequalities in 2024. What are, if there are any, the health inequalities in heart failure?
Yeah, so a few really. In our survival analysis, which if anybody wants to read it, was published in the BMJ a few years ago, 2019, we looked at overall survival trends, but we also looked by socioeconomic quintile. So we looked at the most to the least deprived in 5 different groups. And what we found was there was a 6-month difference in survival between those in the most deprived compared to those in the least deprived quintiles. So that on a 6 months doesn't sound much, but on a population level, that's a huge amount of life years lost in terms of heart failure survival, purely related to being in the most deprived proportion of society. And we do see that, unfortunately, in a lot of conditions, but our data particularly showed this for heart failure. So we do need to make sure that the diagnosis is made across the board, across the range of socioeconomic demographics, to ensure everyone can access the treatments that we know improve both quality and quantity of life in an equitable way. What we also found was that women tend to be diagnosed later with heart failure. So on average, the diagnosis is around 5 years later than men. However, when we looked at age-adjusted survival rates, actually women do slightly better following diagnosis than men. So there may be more of a difference there in potentially the types of heart failure women are getting or how they're presenting, but there's certainly gender differences that we found in our data as well.
Just picking up on the gender difference thing, you see that a lot with women presenting with myocardial infarction. They sort of say the symptoms are atypical. They're not atypical, they're just not what research have shown men present with. Is that sort of same with heart failure? It's not that presenting with atypical symptoms, they're presenting differently from men.
Yes, yeah. So the type of presentation is likely to be different. And also, as clinicians, we may be more likely to consider heart-related problems in men than in women. And also the clinical trials done in heart failure, particularly the ones done a while ago, there were far more men in the studies than women. Trialists have really tried to correct this disparity in more recent trials, but traditionally cardiovascular research, there was much higher rates of men in the trials than women. But the NICE guidance do recommend that the treatments are the same in men and women. So there hasn't been shown to be vast differences in how we should treat men or women, but we do need to think about the diagnosis in both sexes in order to then access those treatments, whether it is a man or a woman.
We do also need to think about ethnicity. And does somebody who is black, could they be presenting differently than from someone who is white?
So there was a large screening study called E-ECHOS, which looked at the prevalence of heart failure in different ethnic groups and found it was actually pretty similar. So the rates of heart failure, there wasn't much difference across ethnic groups. Our data is limited in that we didn't find any difference in terms of survival rates within ethnic groups. Which is obviously a good thing, but it does rely on the coding of ethnicity within primary care, which is sometimes incomplete. But I agree, generally, ethnicity has not been well represented within heart failure trials. Again, researchers now are really looking at the EDI agenda, and when we're recruiting to our studies, we're thinking, how can we recruit men and women? How can we recruit people of all ethnic groups and all backgrounds, deprived or not, so that our research is really representative of the populations that we then want to treat in real life when the trial's done, if it shows positive effect.
Thank you so much, Professor Taylor, for that really interesting discussion. Professor Taylor spoke about this topic at the British Society for Heart Failure annual meeting, and we covered her talk in a conference report on MIMS Learning. So do have a look at the report for more information on improving heart failure outcomes in primary care. And for the research that Professor Taylor mentioned, we will put links to the research on the module of this podcast. So thanks again, Professor Taylor, for all your help.
Thank you. Good to talk to you.
Welcome back. We will now look at 3 things GPs need to know about hearing loss. This is from a Red Flags module by Dr. Camilla Porter, updated by Dr. Pipin Singh. Pat, what's our first key point?
Well, our first key point is about the Weber's and Rinner's tests for hearing loss. I had to go and look these up to find out more about them because I really didn't know how they worked. But my understanding now is that these are used in combination. And the Weber's test is where you put a tuning fork on the middle of the patient's forehead, whereas the Rinner's test is where you place the fork first behind and then beside the ear. If the Weber's test is heard in the middle and the Rinner's test is positive, with air conduction being greater than bone conduction, then hearing is normal. But if there's conductive hearing loss, the person will hear the Weber's test in the bad ear and the Rinner's test will be negative. If they hear the Weber's test in the good ear and the Rinner's test is positive, then this indicates sensory neural hearing loss. And our module has illustrations about these tests.
Our second key point is that some drugs have the potential to cause hearing impairments and tinnitus. These include chemotherapeutic drugs, antibiotics, loop diuretics, antimalarials, and NSAIDs.
And our final key point is that in the absence of obvious external or middle ear causes, NICE recommends referring to ENT in the following situations. Sudden hearing loss that has developed over 72 hours or less within the past 30 days should be referred for immediate or same-day assessment. Sudden hearing loss with an onset over 30 days ago should be seen within 2 weeks, and rapid worsening of hearing loss should be seen within 2 weeks. To recap, Weber's and Rinner's tests can be used in combination to identify the type of hearing loss. Certain drugs can potentially cause hearing loss, And NICE recommends referring to ENT in sudden onset or rapidly worsening hearing loss in a time-sensitive manner. Thanks for listening to this episode of the Clinical Update podcast. All the content discussed today is available on the MIMS Learning website. We hope you'll join us next time for a special episode with a health inequalities focus. See you next time.